So I should preface this by saying that I'm here more in my capacity as assistant professor in Bergen than as an official representative of my institute. I don't think anything I say is controversial, but it doesn't reflect the institute's position per se. Very quickly, and I'll try and hop over the boring stuff, the institute that I work at is the FHI, Folkehelseinstituttet, which reports to the Ministry of Health, and you can see there are other directorates and agencies that have a similar function. The important thing to know here is that the planning and implementation of the vaccination program in Norway was handled by our institute, but was overseen and ultimately approved by the government, which I think is similar to how it was handled in a fair number of countries. As I said in the start, I served as a deputy director to this program. We're about between 70 and 90 people, depending on how you count, organizing this. And as you can see, we organized our work around these 5 work streams, and one of them, called recommendations and prioritization, which I oversaw, had a specific aspect from the outset, which was ethical considerations. And I should say that we had this particular work stream because I proposed it together with a colleague. There's no tradition, no mechanism in Norwegian pandemic response which automatically includes ethics vertically into this kind of organization. This is one of the many timelines from the pandemic. MOH is the Ministry of Health, NIPH is the National Institute of Public Health. I think this goes to the earlier point of speed. The time between being told that a vaccination program needs to be implementable within a very short period of time and being able to produce solid guidelines was very short. You can see that we got the task in September. We'd obviously worked on this before, but as I think most countries, everyone was surprised by the speed with which vaccines became available. The original sort of timeline, I think, was years, not months, that everyone started with. So all of this was very compressed, and we established an external ethics review board, an advisory board, and this group came with an independent set of recommendations. And these recommendations were published separately from the government's report and from the Institute of Public Health's recommendation, but they also were 100% adopted in these recommendations. So the ethics review is the foundation for the distributive principles that Norway ultimately adopted. We convened an expert group, and these are Nordic, I should say, experts in the field that we knew from before and that had published on prioritization in different contexts. You see my name appear there, so I also served as the secretary for this particular group. One of the reasons why we put a secretariat into the National Institute of Public Health was that there was a lot of knowledge related to the vaccines that needed to be accessible to these experts in order to be able to come with a set of guidelines, and I'll very quickly come back to one of those points later. As I said, the main recommendations were followed in their entirety, but perhaps we could just sort of briefly highlight 2 things. One is values, and we've talked a lot about values, and this list is relatively similar to the ones we've seen before, and these were set out in the report. They are values that are reflected in other prioritization documents in Norway. This is not sort of a completely novel approach that we came up with good reason. You can see that reciprocity is in gray at the bottom. There was no agreement within the expert group whether or not reciprocity should be a guiding principle. But these other principles were agreed upon quite quickly. And then I think what did most of the heavy lifting at a later stage was to be very specific about goals. What is it that you want to achieve with a vaccination program? And the important thing here is not just that you have goals, but that we actually ranked them. And this ranking also continued throughout the rest of the prioritization process. Notice that the highest ranked priority is to reduce the risk of death, not to maximize QALYs, not to reduce DALYs, not to do any of the things that a lot of prioritization plans that look at healthcare resources more broadly tend to do. But the argument of the expert group here was to say that in a pandemic situation where lives are at stake and entire population groups, the elderly, the particularly vulnerable, are at increased risk, we cannot afford to go into some sort of DALI or QALY calculus. We sort of need to protect life as well. That has a value in and of itself. But this has huge implications for how you distribute vaccines later. So being clear about this in advance was crucial. We published this, as you can see, on the 15th of November. As everyone remembers, vaccines became available later. There was public discussion about this. This was launched with a note to the press. There were interviews of people in the working group after that. So this was well established as a foundation principle by the time that vaccines became available, and as I said, also was a part of the strategy. If we look at what was ultimately sort of recommended, both in this report, but then because it was adopted in its entirety also in the National Institute of Public Health guidelines, was that criteria for prioritization should look at three groups. One is medical risk factors, with age actually being a medical risk factor here. One is geographical differences. Norway actually implemented something called geographic prioritization, where in later stages of the vaccine distribution, areas that had high incidence over time received relatively more vaccines than other areas. And the third one, uncontroversially, is professions, and here we're mostly talking about healthcare workers. What was important to notice, and this is something that was mentioned in earlier talks, but I think really applied across the board for the pandemic, was that we made decisions under uncertainty. And the uncertainty applied to so many factors that in essence you were discussing how to distribute something that you didn't know quite how it would work or whom it would work on, and that would be available in an unknown quantity at an unknown moment in time. And that makes it very difficult to come with a concrete set of recommendations. So we didn't know which vaccines would be approved by the European Medicines Agency at the time that we wrote this. We didn't know anything about the delivery schedule, nor did we know anything about packaging, and I'll come back to that later. We didn't know how we could distribute those vaccines nationally. Recall that requirements such as an ultra-cold chain were only available as public information as late as October that year, which means that we had to prepare for an entirely new distribution model that Norway wasn't prepared for. We didn't know anything about storage requirements, shelf life, how long after you'd opened a vial could you still pull out doses. All of these things mattered. But most importantly, I think we didn't know anything about the vaccine effectiveness in different age groups, and we didn't know anything about transmission. And obviously, these two are relevant in terms of what kind of strategy you adopt. In a sort of simple example, if you have a vaccine that is very bad at reducing transmission, but very good at reducing mortality in certain groups, then obviously you should vaccinate the groups with a higher mortality risk first. On the other hand, if you have a vaccine that's very good at reducing transmission, then other strategies might suddenly become available to you. So in order to account for this, we felt it was wrong to have one set of rules. Instead, we went for something that we called a dynamic prioritization model. And this was based on 4 scenarios that were the foundation for epidemiological thinking at the time in Norway. And these were essentially planning scenarios for how the state should respond in different phases. You can see the 1A, 1B, 2A, and 2B. The point was to say that a vaccination strategy should, as far as possible, be aligned with the rest of the pandemic response. So what we did was we looked at each of these scenarios, and then we looked at who should be most prioritized in the different scenarios. And essentially what you see here is that there occurs a flip in a situation where you have uncontrolled spread, simply to account for the fact that in that kind of situation, healthcare workers need to be prioritized out of a different consideration, which is that suddenly you're looking at keeping up capacity in the healthcare sector. Whereas if you look at a control scenario, you might say there's very little risk for healthcare workers, but there might be some risk groups, and those should be prioritized. Recall, this is information from the early days before the vaccine was available. If we would still publish this the exact same way now is a different question, but it was the idea sort of to say that we need to be prepared for different scenarios here. And we ended up with this list. These are in Norwegian, but you see that helsepersonell is healthcare staff, and then sykehjem is sort of old people homes. And you can see that the black line on each of those indicates when we had vaccinated everyone, or we'd offered everyone in that group first dose. So you can see that we pretty much followed that prioritization order down the line, with the exception for healthcare personnel, and I shall come back to that in a second. So I think there are some lessons here to be learned in terms of what went well. We were very good at the beginning to vertically integrate ethics into the decision-making. I think that's a relatively sort of novel approach, to really say that at the planning stage, you have an ethics group, it's integrated into a public health institute, or connected to a public health institute, and it produces those recommendations which other decisions are then based on. We agreed on principles, but I think not just principles, but also goals in advance, and we found that helpful at later stages. Being able to refer back to goals makes it easier to resolve conflicts. Everyone has a legitimate claim when there isn't enough vaccine to go around, but people can understand that if you say, look, this is the goal we ranked highest, and another group has a greater claim based on that goal, not because they're worth more than you, then that might help. It doesn't resolve all conflicts, but it helps. And publishing these guidelines way in advance before vaccines were available also meant that people could engage with them without actually discussing where do these doses go in practice. We were clear about the need for revision. We didn't say that this is sort of the one way of distributing vaccines. We called that dynamic prioritization, but I think other plans, living documents, as were mentioned earlier, alluded earlier to, are similar. And we prepared for different epidemiological scenarios because we didn't know how this would play out. There are things that we didn't fully anticipate, and perhaps we could have learned from prior pandemics, but certainly things that I think are important to take with us in terms of lessons for future pandemics. One is that you can agree on principles and goals in advance, and it's actually not that difficult to get people to agree to them. The nitty-gritty starts the minute vaccines are actually available. Those two are, qualitatively speaking, completely different scenarios. Everyone is in favor of solidarity as long as it doesn't impact what you have. Once people realize that vaccine distribution is a zero-sum game, and what I give to one person I have to take from another one in these early stages, the mood changes. And I think that's the next point as well. Interest groups, by definition, represent the interest of one group. It is not their job to think holistically about the entire system. But that also means that some people demand very loudly that they be prioritized in a situation where it's very difficult to see whom we should take those doses from. The question, who would you like us to deprioritize if we prioritize you, was usually answered with, well, that's not my job. You need to decide that, which is true, but it's an unresolved conflict at the bottom of this. The same is true for solidarity. In the beginning, everyone agreed that this was a good idea and that areas with high incidence should get more doses. This lasted for 2 to 3 weeks and ended up in a massive discussion in tabloid media where heads of individual municipalities said that, you know, rich people in Oslo get prioritized, whereas we up here, we don't get our doses, which is not an ethical argument for or against anything. It's just to say that there was a potential for conflict that we didn't really anticipate to this extent. There was also, I think, some confusion about how indirect and direct effects of the vaccine were related to the goals. So one example of this is to say, if your overall goal is to reduce mortality, then you should vaccinate, and this was an actual argument that was being made, you should vaccinate truck drivers first. Because all of Norway is dependent on truck drivers to deliver food. If you don't deliver food, people will die within a couple of days. It is one line of argument, but it relies completely on the indirect effects of vaccination. We said very clearly we want to focus on direct effects. Does the vaccine prevent people from dying? But there are scenarios that are imaginable where one might have made a different choices about this. The other is that this was a national guideline. And again, this is important because a lot of the criticism that was raised was about why don't we send these doses to other countries that are more deserving, which is a fair point, but it's a separate point. And the mandate of a National Public Health Institute does not extend to that. So we, in essence, were given a number of doses and we had to distribute that within a country. And I think making that clear in the beginning is important. And the point that I want to spend a little bit of time on, if I have, is that definitions ultimately are the crux of the problem. Because we can agree in principle that a healthcare worker should be prioritized. But the question of who is a healthcare worker in this context becomes very important when everyone wants to receive a vaccine. And this may sound pedantic, but it actually ended up being one of the most challenging things that we faced. And just very quickly, we have good data available in Norway, so we went about this in a relatively scientific way. We used the Norwegian Labour and Welfare Administration data, which classifies people in employment by categories, right? So we could actually answer the question, who's a healthcare worker, by saying, well, there's a category for these people and I can choose them. And then we said, okay, they need to work in a relevant institution, because someone who is trained as a doctor might work, let's say, in health policy, where he doesn't have any patient contact. So we could exclude those people. And we then had to make a call about if you have the right training and you work in the right organization, do you have direct patient contact, which we felt was relevant at that point as a distributive principle. So for instance, a physician who worked in hospital administration might be excluded on these criteria in the initial rounds. Recall that we had very few doses available. We're talking about a few thousand doses, I think, in the first week. So this really mattered. But inevitably, even with this kind of information available, you end up with incredibly difficult decisions. So here's a question. A taxi driver who in a rural municipality takes people to regular treatments, essentially takes over a healthcare function. Are they a healthcare worker? If you have a chronically ill child with an immunosuppression, do you, as the caregiver for that child, have a healthcare worker status? These decisions had to be made, and they were made ad hoc. And they were made by the National Institute of Public Health. I chaired a weekly meeting where we made decisions about this. But this was about as far removed from any sort of democratically steered process as you could be. This was ad hoc decision-making in those situations. So what we should do differently next time, and that's my final slide, I think it would help to have a clearer mandate. As I said in the beginning, we started doing this work more out of our own initiative and not as a sort of standing committee. I think this is both a matter of legitimacy, but it was also perhaps prevent people who do this work and do it voluntarily being attacked for having given an opinion, which is something that they unfortunately experienced. We need to be very specific about what level of importance we assign to ethics, because it's one of many decision-making criteria in this kind of situation. It's not the one that sort of steers everything. There are other considerations, national security and so on and so forth, that also economic factors that also factor in. And I think if we want to not just rely on one report in the beginning, but we want to keep this going, then you need the resources to do this throughout. And we can prepare for future pandemics by doing a lot of the groundwork, which we had to compress into this very short time, and that very much mirrors what was said earlier, into peacetime when we have better time available and can involve more stakeholders. Thank you very much.
Thank you. Thank you very much. I think your prioritization strategy, you called it dynamic, is very interesting. And a similar thing I heard when you try to work within the field of artificial intelligence. They talk about ethics by design. You should be present from the first stage and throughout the process to get ethics involved. So you are doing something similar. But in your case, it seems to, and might be a too detailed question, but the goals are important. But when you put the goals on the screen, they look very precise. But they too are imbued by uncertainties.
Yes, by uncertainties
and that causes a problem, doesn't it?
Yes. Yes, and I think if that's perhaps the most important takeaway is that it doesn't matter at which level of detail you can plan. Yeah. You need to be prepared for making follow-up decisions, and you cannot sort of agree on one set in advance. And I know this seems really obvious, but I think given that we had such good registry data, I mean, we distributed vaccines to individual municipalities based on that we knew how many people had which underlying chronic disease in which stadium. Like that is possible, right? So you think, well, there's no need for prioritization anymore. You know, I've got all the data that I need, but you're never accounting for the complexity of how people live, what their actual needs are, and how they differ between different regions.
Does this mean that your system very much rely on your individual competence and that you are a rational, ethical person in the group?
I think ultimately it always comes down to that. You cannot automate the system and then still assume that it makes good decisions. And I think what we proved is we went about as far as you can in any high-income country with using registry data, and even that doesn't resolve the problem. So when people say, oh, but we just need better data, and then we'll be able to make those decisions, I think that's a fallacy, which is not to say that better data doesn't have a value. It's just to say that there will still be value judgment and normative judgments involved.
Okay. Thank you very much.
Thank you.